All right. Welcome everyone to our CAB Chat and Chew. We have a wonderful guest speaker, Dr. Emily Mrig. Before I introduce Dr. Mrig, I wanted to at least share why we wanted to have this topic on precision medicine. So we have a working group on within the community advisory board of the Cancer Center that's interested in trying to explore equitable access to precision medicine for our cancer patients and our communities at large. And so, given previous discussions that have taken place and ideas moving forward, I thought it would be a great time to bring in Dr. Merrick to share her research, and she's going to present on breaking down barriers, patient and community partnership in precision medicine access. Dr. Mrig is an assistant professor in the Department of Clinical Pharmacy at the Center for Translational and Policy Research on Precision Medicine at UCSF. She's an interdisciplinary scholar with training in public health, health policy, and social science, and investigates differences in healthcare access, particularly in precision medicine, cancer, and undiagnosed conditions. Her current projects focus on identifying cost barriers to molecular diagnostics and targeted therapies for cancer patients, utilizing innovative mixed methods approaches, including AI analysis for electronic health records, and integrating narrative patient experience data to generate evidence supporting the fair adoption of precision medicine technologies. Please join me in welcoming Dr. Mrig. We're very excited to have you here and look forward to hearing your talk. And would hopefully you have no issues joining or sharing your screen, and we're happy to have you.
Thank you. It's really a pleasure to be here. I'm going to go ahead and share my screen. I can, it'll let me. 1 second. Sorry, I don't know why it's. There we go. How's that?
Nothing happening yet.
Okay.
It's coming. It's coming.
Okay. It's coming now. Okay, wonderful.
Yeah.
Great. We did it. It's really a pleasure to be here. Thanks, Dr. Palmer, for the wonderful introduction. I'm just super excited to have the opportunity to come and share my work with this particular group, especially because working with the community is so important and critical to everything that I value in my own research. And so I'm going to introduce myself very briefly. I feel like Dr. Palmer did such a lovely job, like I said. Again, my name's Emily Mrig. I'm an assistant professor in the Department of Clinical Pharmacy and in the Center for Translational and Policy Research on Precision Medicine. And so we're a very specialized center. My work is really interested in analyzing disparities in access to precision medicine. I focus primarily on genomic testing, and then target interventions that we are able to identify for patients based on the results of that testing. And what I'm most interested in that area is really these cost and coverage factors in shaping access. I do this in a number of areas. I really think about a lot of my work as being kind of bigger picture, but I've studied these issues primarily in hereditary cancer, lung cancer. I do some work in the rare and undiagnosed disease space and end-of-life space as well. And I use mixed methods, but I really consider myself a specialized expert in patient experience, in eliciting patient voice, including patient voice. And that's really, like I said, at the heart of what I do. And so I'm here because I want to really learn from you. You know, I'm going to present my work and some things that I think might be of interest based on what Dr. Palmer shared in some prior conversations with me about kind of why the topic of precision medicine was of interest to this particular group. And it's always important that my research is reflecting the needs of our community. And so I also want to learn from you, what do you think about this work? Where should I take it? How do you want to be involved? If you want to be involved, all of those kinds of things. So I'm really looking forward to the conversation that we hopefully will have at the end of what I'm going to present here. So precision medicine, we kind of use that term interchangeably with other terms like genomic medicine, personalized medicine. I think of precision medicine specifically as the use of genetic information, usually gathered through a genetic test, to personalize our approaches to prevention, diagnosis, treatment, and disease management. But in order to do that, we need to get prompt genetic testing results in order to actually personalize these kinds of targeted therapies when we're talking about cancer, but any other kinds of prevention, treatment, any other kinds of disease management. And yet the pace of the discovery, precision medicine, it's rapidly emerging, and discovery is happening faster and faster all the time. And yet the rate of discovery is really far exceeding the rate of implementation. And because it's not being implemented evenly across all populations, there's really disparities that are the result of that. And so when we look, this was a really interesting study that was published in 2024. And this was a study looking specifically at lung cancer patients, and it was looking at the uptake of molecular diagnostics among lung cancer patients. And so looking at survival differences of individuals who did and did not have genetic testing. And so what you see here in the red line are patients who received testing. And on the blue line, we see patients who did not receive testing. And there's a statistically significant difference in survival outcomes between people who are receiving testing and who are not receiving testing. And that is really, when we talk about, well, why does this matter? Why do we need to get patients access to this testing fast? This is really to me, like a very jarring kind of image of like, wow, this makes a serious difference. And yet one of the key things that this particular study really highlighted is that there were differences between these two groups in terms of racial and socioeconomic disparities that distinguish these two groups between those who are getting access to testing and those who are not. And so when we talk about, there's a lot of reasons why there might be barriers, why kind of, precipitate these sorts of disparities. And yet what we know to be the most significant barrier are really these cost and insurance coverage challenges. And so why is that? In this space where, discovery is happening really fast, clinical guidelines often struggle to keep up. There's all kinds of clinical guidelines that come from professional societies ranging from, the NCCN guidelines that are specific among our cancer, our oncology specialists, but they're also primary care guidelines. There's a lot of different guidelines. And insurance payers will pick and choose among the guidelines that maybe they like or dislike, or what they prefer in order to determine how they're going to make their coverage policies. And you can imagine that that's uneven and inconsistent. And so as a result, that means that there's inconsistent and uneven coverage for these newly emerging diagnostics and genetic tests, especially for some of the newer tests, things like ctDNA testing, circulating tumor DNA testing, which I'm going to talk a little bit more about today, but also for our whole and exome genome testing and other kinds of new next generation sequencing tests. And so without adequate coverage or inconsistent insurance coverage, there's a lot of insurance denials in the space, or there might be other payment barriers because these are high cost tests. And so what this means is delays for getting access to that testing. And when you have a delay in getting access to the testing, you delay treatment, you worsen treatment outcomes. And so really, the bottom line is we need to be able to facilitate access to payment, whether that payment is through an insurance coverage, is through financial assistance program, or out of pocket, or some other means of paying for it, in order to improve our outcomes and promote equitable precision medicine implementation. And so that's really what I've been focusing on in much of my work. So financial assistance programs, so what I'm going to share in the next couple of slides are actually from a recent paper that I published with a couple of co-authors, one of them here at UCSF, Dr. Catherine Phillips, and another one of my colleagues at Yale, Mark Schlesinger. And we wrote a paper recently sort of highlighting some of the unintended ethical issues around financial assistance programs. And you probably have heard of these in some way, even if you haven't explicitly known that you've heard of these financial assistance programs. They're most common in the pharmaceutical space. And so you probably have heard a lot of pharmaceutical commercials over the years. They seem to come on every 5 minutes. And maybe at the end of that commercial, you've heard that little blurb at the end. It's like, if you can't afford your medication, AstraZeneca can help. Well, when you hear that kind of statement at the end, that's a financial assistance program. And so they've been really prominent in the pharmaceutical industry. They're a way of helping patients that lack insurance coverage get access to the necessary medication or get access to a particular medication. And yet they're becoming more prominent in the genetic testing space. And so what's interesting is, a lot of my work and the work of my colleagues is really focused on cancer, but a lot of these issues that we're going to talk about over the next couple of slides, they really are relevant to all kinds of genetic tests. So ranging from prenatal testing to rare genetic disorders to pharmacogenomic testing for particular pharmaceutical targeted pharmaceuticals. So what are financial assistance programs? Sometimes I call them FAPs. So these are programs, like I said, they're designed to help patients access medically necessary genetic testing when insurance doesn't cover it or cost sharing is too high. So the out-of-pocket cost for the patient is going to be quite expensive. So these applications, they usually require some kind of proof of financial need that can be documented in some kind of tax form, insurance denial letter. It could be a letter of medical necessity from your provider. And then when approved, the program might cover the full cost of the testing or reduce the patient out-of-pocket cost. So it could be like, $75 for the testing for the patient. And there's different types of financial assistance programs. So they come in sort of three flavors. The first and probably the most dominant that we hear about in this landscape currently are the manufacturer and laboratory programs. These are offered through the testing companies themselves and manufacturers of the test. So companies like Myriad, Invitae, Foundation, every single manufacturer, I can't think of one that does not have their own type of program. Often these particular programs require commercial insurance coverage in order to qualify. So you've got to show my insurance would not pay for my testing. And so then you will qualify for one of the manufacturer programs. If a patient can't get access through the manufacturer program, they might look to a hospital or health system program. So these are provided by medical centers for patients in their system. Typically, these have fewer eligibility restrictions. They tend to be for people that don't qualify for the manufacturer programs. Maybe they have public insurance, Medicaid. They are uninsured. And typically these programs, as we'll see, they tend to be more transparent about who's utilizing their services because it benefits the medical center to talk about who are the people in their community that they're helping. But unfortunately, these programs typically have less resources. They have less funding. And then the last kind of category of financial assistance might be through a nonprofit or an advocacy organization. These tend to be run by the patient advocacy organization. So, for example, FORCE, which tends to help folks that have hereditary breast and ovarian cancer, or NORD, which is an organization that helps folks that have undiagnosed and rare disease. But these patient advocacy programs, they're not just interested in testing. They're really trying to focus on helping people get access to treatment or related costs with treatment, things like parking or transportation to get to their medical appointments. And so they might help with testing, but sometimes not. And so these are often thought about as kind of the last resort after these other two options have been exhausted. So those are our three types of assistance. And so a lot of what the overall, I would say, a lot of the research has shown, including my own work and my colleagues' work, has really emphasized a couple of key points in terms of the promise of these programs. First of all, a lot of experts view these as being crucial in transforming genetic testing because they improve accuracy and accessibility. And so, the more people that are getting access to this testing, the more data we have, the better we're able to make sure that these tests can be useful for a diverse population. They're also, clearly vital for safety net settings and, strengthening safety net environments and supporting our underserved patient communities. That's all the promise. And so, if we were to see this play out, like what does it look like? So a patient comes in with a high deductible plan, they get the $3,000 test. I can't afford to pay that. So then they find out that there's a manufacturer program. Their hospital financial counselor successfully helps them navigate through this application process. They get their testing quickly. They get the results. They guide their effective targeted therapy. And for the time being, the patient avoids some kind of financial toxicity, and I say for now because we know that there's all kinds of other ways that cancer treatment can, be very financially stressful for folks. But, in this particular circumstance, this is what it looks like when, these programs are working really well. But of course, the flip side, the reality check is that, first of all, programs are typically, like I said, they're prioritizing the programs that are most used, the manufacturer programs, typically are prioritizing our commercially insured patients. That leaves our Medicaid beneficiaries without needed support. And so while these patients can maybe find help through other charitable programs, again, access is not always available to those programs. And so access, that's not always a dependable sort of backup option. And this really then leads to this, again, a fragmented landscape of availability of programs. And it really varies by where the person is receiving care, who's available to help them, guide them through this process, who are the providers, who have the providers partnered with in terms of manufacturers or industry sponsors to provide programs, that's really fragmented. So it's adding to our unequal access of financial assistance programs just for the testing, not even then all of the cascading, potential, how this information is going to be used to inform the rest of the person's care. These also require a lot of paperwork. Like I said, you need tax forms, you need medical letters, you need insurance documents. And so this really becomes a disadvantage for resource limited or low literacy patients. I mean, I've talked to quite a few people over the years. I can't tell you how many patients I've talked to where they will get out their folder of documentation and they will show me what they've had to provide in order to have proof that they qualify for a particular financial assistance program. And not everybody is able to do that. That can be really challenging. And so certainly, there are patient navigators, there are financial counselors in some provider networks. But even in safety, especially in safety net providers, they just find it really challenging to help with this kind of extensive documentation, and it takes time. And it becomes overwhelming, I think, in a lot of cases for really well-intentioned providers and clinicians to help their patients kind of go through this process. And I know talking to folks over the years, again, you hear the frustration, you hear the desire to want to help, and yet it's really, really cumbersome. And so at the end of the day, who are the people that are actually able to go through this process? Oftentimes it's wealthier, mostly white individuals that have better insurance. It's not necessarily the underserved groups that we would think that these programs are meant to help. There's also some issues with privacy concerns with the data sharing practices. For a lot of the manufacturer programs, they lack transparency about how the data is going to be used. And so a lot of patients and providers are really uncertain about what does it mean if I participate in this program? Like, how will my genetic information how will it be used? And so and it's a key here, again, thinking back to what's the motivation? Why would a manufacturer want you to participate? Why would they want you to get access to testing? Well, a lot of the manufacturer programs are actually sponsored by pharmaceutical companies that partner with the manufacturers of these tests because they want to be able to identify patients that can utilize their particular therapy that they've developed, or they want to have data about the population in order to identify new treatments down the line, right? So so a lot of times there's privacy concerns in terms of allowing sponsors who are paying for these programs to access patient data for research. Now, some people might be completely fine, understanding that, they need to have the data in order to develop these new treatments. And yet, without transparency about how that data is going to be used, we really are not allowing patients to make their own informed choices about it. And so this really puts clinicians in these ethical dilemmas, right? They want to encourage participants or their patients that might have financial constraints to access testing, and yet they might feel kind of this ethical dilemma of kind of pressuring patients into something that they might not fully understand the implications of where their data is going to go. And so again, then that raises questions about patient autonomy in terms of allowing them to make a meaningful choice regarding their own data sharing. And a couple of other things, to be aware of. One is sustainability risks. Again, thinking about the many conversations I've had, clinicians often express sort of a concern that, well, what if the industry decides that they, don't want to prioritize my population, my geographic setting, my clinic, or what if they just decide they have other priorities and these programs go away? What is that going to mean for my particular population? Dr. Palmer actually mentioned something to me at one point about, if a provider leaves, sometimes there are clinicians that are really excited about these programs. They bring them to where they're treating patients, and then they depart, and then that kind of leaves a vacuum because no one's there to kind of pick up these relationships with the manufacturers to bring these programs to that particular population. And so that really creates kind of like this sustainability challenge for how are we going to actually make sure people are getting access, and this is what we're using to pay for testing. And then there's the implementation challenges around the fact that there's so many different types of genetic tests available on the market. They all have their own financial assistance program. How do you keep up with the requirements, the administrative piece? And so when you talk to financial counselors who are helping patients through this, they'll tell you they got bogged down because they needed to get patient access to a particular test. They were not familiar with the requirements. It took him a couple of weeks to go through. And in the meantime, that patient's getting delayed access to the testing. And it's just a complicated, getting them the financial assistance, again, delaying therapy that they might need. And so all of these things are obviously hitting and impacting resource limited areas the most, especially for patients that are in health clinical settings with that lack sort of these dedicated navigation resources. So just kind of summing up what I've learned from some of these prior studies, yes, financial assistance programs, they absolutely can be life-changing. But there's challenges, right? I mean, there's challenges, including risks and privacy concerns that patients face. There's accessing financial assistance can be complex and can be cumbersome. And yeah, providers absolutely agree with patients, but also express these frustrations with how fragmented these programs are, and they have limited time to assist patients. And yet still, for people who are getting access to testing, whether or not it be through a financial assistance program or through insurance, we still don't actually have any kind of empirical data about who's accessing financial assistance programs. We have sort of this anecdotal data. We get a sense that, yeah, it's likely being accessed more often by wealthier, better, more comprehensive insurance coverage, and folks with more comprehensive health insurance coverage, et cetera. And yet we haven't had any real empirical data in the past because the data has not been available, maybe sometimes because of data privacy issues on the manufacturer side, and also methodological challenges just in the way that we actually code for some of these things. So just on the kind of nuts and bolts of how we're collecting data about billing and reimbursement in this space. And so that brings me to a lot of the research that I'm focused on right now. In my NIH Career Development Award, my KO1, I really set out to figure out answers to these questions. And so in this particular study that I'm primarily focused on at the moment, the first aim is essentially using machine learning, using AI and electronic healthcare record data to overcome those data and methodological challenges in order to identify patients who have gotten testing and who have not gotten testing. And for those who have gotten testing, how was it paid for? Did insurance pay for it? Did a financial assistance program pay for it? Was it paid for out of pocket? And so I find this really exciting because we've never been able to answer this before. And so that's not what I'm going to focus on in the remainder of my slides here today, but always happy to talk more about that part of the project later on. But in the second and third part aims for the project, that's where I am actually then engaging patients, engaging our providers at UCSF and in the community to learn from patients who did and did not receive genetic testing, to understand what their experience was like, what kind of resources did they know about, did they use, how did they work, and just better understanding individual experiences, and then actually engaging patients with these other staff, faculty, clinicians, and hopefully insurance payers as well, to then identify and prioritize some interventions to help address some of these cost and coverage barriers, which will then lead to future work. So I'm doing this through a case study of circulating tumor DNA testing, or ctDNA testing, for lung cancer. So yes, I think that this is my hypothesis is that this issue is pervasive across different types of genetic testing and different types of conditions and cancers. But I'm using this case study of ctDNA for lung cancer. For one, because ctDNA for lung cancer, this liquid, otherwise called liquid biopsy, is really we have clear clinical utility in this space. And so what is ctDNA testing? Traditionally, if you have a lung cancer diagnosis, the first thing that you'll do is get a tissue biopsy. We want to biopsy the tissue in order to sequence it to then determine the best targeted therapy. But for a lot of folks who have advanced cancer, we just cannot get a tissue sample. And so that limits what kinds of therapies that we can actually get them access to. Whereas a liquid biopsy, it's much less invasive. It's literally a blood draw. And not only that, you get your results faster than a traditional tissue biopsy, which then, of course, shortens time to treatment and improves outcomes. As we saw when we look back in that graph that we saw originally of people who did and did not get genetic testing, this actually even widens, that takes it a step further. It's who got tested, who got this faster, their results even faster than those who might have traditionally gotten a tissue biopsy. But this is new technology, right? And so even though we have evidence of clinical utility, our clinical guidelines are struggling to keep up, insurance coverages again, and even it's all the things that we kind of have already been talking about. And so in order to overcome those kinds of cost and coverage barriers, sure, some hospitals have resources, others don't. It really, again, depends on where you're getting care. And we really don't have a lot of evidence in terms of like, what are the resources, institutional resources that are working and not working. And so, like I said, my aims 2 and 3, they really are engaging patients. And why does this matter to me? Why am I research? I mean, really, quite honestly, research has often overlooked patient experiences when it comes to payment barriers or any kind of insurance. We typically do not engage patients when talking about insurance issues. We tend to prioritize clinical outcomes or prioritize provider views. And yet when we develop interventions or programs and they lack any kind of patient input, we found that it oftentimes fails to meet their needs. And so what I found is that lived experience is essential to identifying what's truly going to work for the population that I'm interested. Patients know, they understand what works in navigating the healthcare systems, and that's been so clear to me over the years of work that I've been doing. And also really important is making sure that we understand the entire journey from maybe the minute of diagnosis, maybe even before that diagnosis even occurred, to getting, the recommendations for testing, to understanding their treatment recommendations. So I really try to understand the full story. And then, putting that individual experience in the context of the community is also really vital for creating and identifying some of the real world solutions that are going to work. And so understanding how that individual's experience sort of reflects the community and then engaging community, that's really key here. And I think really sort of aligns with what your philosophy of engaging the community is as well. How do I do that? So I am really interested in a particular method. It's called the HEXI method. This is pretty much the gold standard for conducting and eliciting patient experiences with healthcare. I usually, when I sit down with an individual, our conversations can last 2 or 3 hours. So I start by inviting the person to share their story. It's an open-ended question. Sometimes people will talk for 5 minutes. Sometimes people will talk for not 3 hours, but like 30. I've had people talk for 30 minutes and I just want to listen. I just want to hear, what do they have to say and what do they have to share? And sometimes this is cathartic for people. People have shared so many times. No one's ever asked me to share my experience about what I went through. It just depends on the individual. And then from there, we talk more about their experience. And then in this particular project for the KO1, the next step is inviting participants who are interested in participating in a focus group with other patients and learning from them and identifying kind of solutions from that group. And then bringing everybody together in these, and I call them multi-level stakeholder meetings, but it's really just a conversation with patients, clinicians, staff, hopefully, like I said, payers as well, community members, and identifying the best solutions to help others overcome the cost and coverage barriers that they encountered. And so why do this? I mean, the reality is that when people ask me, you all probably like, oh yeah, it makes sense to bring everybody to the table, but every group is going to see this problem differently. Patients are going to share their lived experience. And this is a quote from a participant in a previous study. I figured the oncologist would be too busy and I didn't think to ask the nurse. And then, the clinician heard that, and the clinicians will oftentimes understand the clinical urgency. They see patterns across patients, beyond the individual. And then you have staff there, social workers, navigators, financial counselors who know the system mechanics and how it breaks down, where it breaks down. And so bringing all of these perspectives, triangulating them, that is where I think, the real innovation, the real identifying what's going to work and what's not going to work. And so that's really, my goal with this study is, together identifying the top interventions that are going to improve access to payment, not just in an academic medical setting, but really, this is where engaging our community health clinics as well is going to be vital, because what works at UCSF for our patients here is not necessarily what's going to work everywhere. And so then from there, develop and testing these interventions will be the next step in a larger study. So, in summary, I think clearly, financial assistance programs are great, but they're not a solution. They're really this Band-Aid and an imperfect one, that can sometimes leave some of the most vulnerable behind. I think it's important for patients in particular to know that cost barriers are policy failures. They're not their own. I think patients take on the burden of the financial stress, and yet we need to find solutions that are taking that burden away from them, alleviating that. We know, hopefully it's clear community input is essential. It's not optional. We need to make sure our programs are designed with patient and community input. And that, the idea is that we're co-creating solutions and not just documenting problems as part of this work. And so with that, I would be remiss if I didn't invite everybody here to collaborate with me. For this particular study, I'm going to start recruiting participants in late Q4 2025, not just patients. So if you're a physician or you're somebody in the community who knows somebody who, meets our eligibility criteria, wonderful, send them my way. Love to have them participate in this study. But I'm also planning to interview and work with faculty and staff that have relevant expertise. So if you know about this issue, you might not even realize that you have expertise related to this, but if you have thoughts about what's working and what's not working when it comes to supporting patients and addressing and overcoming, responding to some of these cost and coverage issues, please reach out. I want to talk to you as well. And then last but not least, I always I'm looking for other people that are interested in engaging patient perspectives. Is that something that you're interested in doing in your work? I always would love to talk with others, here at UCSF and beyond about that as well. So hopefully I tried to leave lots of time for conversation. I have some questions too for you all, but I would love to hear your questions as well. But I just want to say thank you. I want to say thank you for your attention, but also for my lovely collaborators here at TRANSPERS and across the country that I've been really helpful in shaping the work that I'm doing and that I've shared with you today.
Wonderful. Thank you, Emily. Really appreciate this insight. Lots of history and background on the programs, the financial assistance programs, and kind of the context of how that plays with affording access to precision medicine testing. So I know that there's a few questions in the chat that we can pull up in just a second, but just wanted to see if there are comments or questions that's in their space now.
Dr. Palmer? Dr. Palmer?
Yes, I'm not sure who that is speaking, but yes.
Sorry, Isabel Duran here.
Hi, Isabel.
Hi, Dr. Emily. I think it would be really interesting, particularly because when we're talking about vulnerable populations and the underserved and the underinsured, if you could describe exactly when precision medicine enters their health lives, so that I think our communities need to understand how precision medicine helps shapes even baseline information and how they need to figure out how they can access it.
That is a huge question. I mean, if you really want to talk about precision medicine, the slogan has always been the right treatment for the right patient at the right time. And that seems very vague, but I mean, it really is across the lifespan. I mean, it's starting with prenatal testing. A lot of women, especially women who are, over the age of 35, who are having prenatal testing done. It's often recommended all the way, across the life course, right? So newborn sequencing is done. That's a public health program as newborns sequencing screening, which is done then to identify potential, oftentimes metabolic conditions. Then there are folks that, okay, put that aside later in the lifespan. Folks might have a family, health history of cancer. At that point, ideally, you should be all patients, doesn't matter if they're, who they are, where they come from. If you have a family history of cancer, should be receiving some kind of hereditary genetic testing to identify to see if you have something like a BRCA1 or 2 gene, for example. And then once you have a cancer diagnosis, that's primarily what I was talking about and focusing on with the work with ctDNA testing. That's to determine the type of treatment you have. So all of these things are preventative. When we're talking about getting hereditary genetic testing, a lot of times what the ideal situation would be that you have a family history of cancer. You get the genetic test, you identify if you have a variant that's associated with cancer. Now you can help to prevent getting cancer. How do you do that? Well, first is screening. You have access to, whatever screening that you need. A lot of these variants, unfortunately, they're associated with, BRCA1 and 2. That's not just breast and ovarian cancer. That's prostate cancer. That's, colon cancer, that's prostate cancer. There's many other pancreatic cancer. And so how do you screen for all of those? So it becomes a cascading impact of what do you do with this knowledge? And so in terms of at what point does it enter, what point in your life does it matter? I would argue that pre-birth is really, prenatal is really when it starts to matter. But realistically, it tends to be later in people's lives. And so it's important for patients to know that they should be, and primary care providers should also be in having these conversations with patients, early on before when people can make preventative decisions based on this information. I'm sorry if I didn't, I hope I answered the question, but it's such a big question that I feel like there's many different paths I could continue going on from there, but please follow up if you have.
Emily, I don't disagree. And Dr. Palmer, please tell me if I should be quiet and there's another hand up, because I can't see, I'm on the phone here. But may I ask as a follow, Dr. Emily, I absolutely agree with you. It's almost like you have to have a baseline risk diagnosis out of you, coming out of the womb, so that you know what to prepare for in the potential future to keep yourself healthy. But I'm also wondering about, when a woman does a BRCA test because of family history. And of course, then you have to engage other family members. The smart thing to do is you talk about cascading, all of the costs involved and who pays for them, and how do you begin to take care of perhaps numbers of members of the family who are at risk as opposed to just that one woman. This creates, to me, structural as well as cost issues.
Absolutely. And this is actually another forthcoming paper that's actually in press right now that I wrote explicitly to talking about the disconnect between precision medicine, like the expectation of that information. Like the idea is now you've got information, and presumably now you should be getting those screenings, doing what you need to do like individually to address your risk if you do have a BRCA1 or 2 mutation or variation. But then there's also what you alluded to this, what we call cascade testing of other possibly affected family members that might also be at risk for a BRCA1 or 2 in this case. And so getting them, I mean, so in this particular paper, I talk about people's experiences and what their experience is over time. This is where having that whole story is really important. What it shows is it's a disconnect between the expectation, the paradigm of precision medicine. And I call it, actually, the name of the paper is Zones of Conflict, because it's literally a conflict between the precision medicine paradigm and health insurance paradigm, because health insurance, they don't want to pay for that, that follow-up. They don't, and in many cases, they're under the Affordable Care Act, it obligates payers to pay for anything that is a USPSTF, which is the United States Preventative Task Services Task Force, Preventative Services Task Force. Anything that they say is an A or B preventative recommendation, they're obligated to pay for. So they might be obligated to pay for genetic testing for an at-risk person, but that payer is not obligated to pay for all of that follow-up care or help them identify, family members that might also need care. And so that's a real issue. And when and I don't think we talk about that. It's one thing to get access to testing. Then what do we do? That's really what, I focus on in that particular paper. And again, here you see it, okay, you get access to ctDNA testing. Well, what about the targeted therapy? We didn't even touch on, who's actually getting insurance coverage for the targeted therapy that can be very expensive. So I don't know, again, like I think if anything, I'm commiserating, but I can also say that, my goal is to make it clear that we need to use this knowledge to help support care, across the entire lifespan and across this entire continuum of care from the genetic test through all the follow-up care.
Great.
Yeah.
Thank you.
Is there anybody else with a hand up? Because
we have a few questions in the chat, Isabel.
Okay, because I have one last comment. Very egregious comment.
How about we circle back to it?
Okay.
Okay. So one question in the chat is, let's see. With historical data alluding to exclusion of communities of color, why were there barriers not addressed?
Yeah.
And I assume, Gary, this isn't referring to the study, but rather the historical perspective of access to the testing in general from all of these companies. But Emily, would you like to chime in there?
Well, all of our data, yeah. I mean, this is the struggle I have in my work is ideally everybody, the only way our database gets better and reflects the population to overcome the bias that exists, because we do have exclusion of communities of color and many other populations in our large genetic databases, is if we get if we do more sequencing across the board, right? And that really, I mean, all of us study, I don't know how, I'm not a part of that study, but I'm very familiar with it. I mean, that's part of what that is designed to do, sequence 1 million Americans and, address some of these gaps in our data. The reality is that it's taking, it takes time to do really thoughtful and good research. And so in the meantime, I think pharmaceutical companies are trying to overcome some of the data biases by just, getting more people to take their test, essentially. Is that a viable way of addressing sort of the historical, issues that we have? I probably would say no. But my guess is that's probably why. I think I'll leave it there, because does it aggravate me to no end that we have excluded, so many people from our data and that it's so biased? Absolutely, it sure does. And so, that makes it really challenging, because so many patients of color, when they do get these genetic tests, end up having what are called variants of unknown significance, because we don't have enough data from diverse populations to really make a meaningful conclusion about what some of their results mean. And then what do they do with that? How do we follow up with them? So it becomes very complicated.
Thank you for that. Another question is it genetic testing readily available in non-comprehensive cancer centers?
Well, it really depends on the type of genetic testing. Yes. So the short answer is absolutely. But what I'm seeing in the data that I have, again, I'm looking at what I've analyzed so far is this electronic health record data from community, from UCSF in this case, academic medical center. And what I've seen very clearly is patients are getting access to testing, but more patients at an academic medical center are getting this newer testing, this ctDNA testing. Most patients are getting tumor sequencing, and they should, unless, like I said, the tissue is not accessible, we can't get a sample. So it really becomes, what I'm really interested in is this moment as novel tests are emerging, coming onto the market, being used. That's happening more in an academic medical setting. But people are getting access to genetic testing.
Right, thank you. Isabel, would you like to circle back?
Yes, because she just raised an issue. Emily, one of the things that we found, and I was doing some research work with both UCSF, UC Davis, and Stanford on different projects. But one of the things that we have found out 4 or 5 years ago is that in federally qualified healthcare centers, even with the family history, genetic testing is not a quality measure, and therefore they're not required. And because they're not required and there's no money to pay for it, people don't get the test. So to that earlier question about can you get it regularly? Yeah, if you pay for it with some private company. But for the most part, low-income people probably won't and can't, going through these safety net hospitals and clinics. Plus, insurance also oftentimes denies getting that extra test. The second thing we found in this work I did with Stanford and some of my colleagues also in the CAB also participated from their different agencies. What we found was that women of color, and particularly women with breast cancer, and Spanish-speaking women, low-income women, we found that they were not getting regular genomic testing after a diagnosis of breast cancer. And genomic testing, which, as you know, and some people might know, is tumor testing. This also determines what particular kind of care, treatment, drugs, diagnostics are going to determine what kind of quality care you get. And if these women aren't getting it, then they're probably getting regular care. And so some people say, well, genomic testing should be a standard of care. And yet it's not being applied equally across systems. So there again, we've got an issue. Your thoughts?
100% yes. Everything that I'm very familiar with that work out of Stanford. I think that's Dr. Kurian's work, Allison Kurian.
And Dr. Patel is who I've been working with.
Yes. Super important work. And there's an increasing voice, and clinical guidelines are reflecting this. Again, this is where it's so interesting that clinical guidelines can say one thing and payers can say, they can even say, I'm using these these particular clinical guidelines. That does not mean that they're actually paying for it. And so that's really the argument I'm trying to make using the data, is like showing like your coverage policy is not actually translating into the care you say you're going to get. And so in order to do that, we've got to have evidence. So that's what I'm trying to show in a lot of the work that I'm working on. But there's an increasing voice across, especially breast oncologists, that every single patient that is diagnosed with breast cancer should get genetic testing, not just tumor sequencing, to inform actual targeted therapy, but it should be getting what you're talking about, which is hereditary germline, which are the genes that we actually pass on. That kind of testing, and absolutely and so it's increasingly clear that should be done. It's not happening. It's especially not happening in our disadvantaged safety net settings in our populations of color, and that is a huge problem. And I will say that there's a significant and growing body of research to show this, and yet we're not doing anything to address the problem. Again, this is where I'm really hoping that where I want to be useful in my research is figuring out how we address this problem. What do we need to do? What do we need to do to get people the pay, like get the, whether or not it's insurance coverage or, you know, if it's a financial assistance program or we, you know, lower the costs, how can we get this testing to communities? So that's something I'm really passionate about and want to be engaged in.
So Emily, if you get the evidence as we're trying to collect, it really is a policy systems issue, which means we have to go
Yes.
to
Yeah.
Capitol Hill, which is dysfunctional about this time. So and therefore, one of the reasons why I think the CAB should know about this is that it is going to require us getting our communities engaged in this policy shift and change, because even with proof that it should be done doesn't mean that insurances will be moved, just as you indicated, and or that the federal level people who are making the decisions about what is a quality measure, for instance, in federally qualified healthcare centers, they need to be convinced. So it is a huge major issue at sort of the top of the food chain where we have to make some movement. So your work helps us build towards that kind of
Right.
movement.
Because technically, like I said, in the case of breast cancer in particular, if you have a family history, you have insurance, any kind of insurance in the United States, you should be able to get coverage for genetic testing. Now, whether, like I said, whether or not you get all of the things, the surveillance, diagnostics, you know, to follow, not necessarily, you know, you're not obligated, but your payer is, and so if they're not doing that, then that is that should be addressed because that is actually a policy imperative. So, and that's, you know, I do think we need to have evidence to show that people are being denied coverage for genetic testing in cases where it's medically necessary.
Yeah.
Thank you for
So
that.
imagine those without insurance.
I mean, yeah, with the uninsured, that's another story. And again, that's where I think a lot of those are where the financial assistance program should, I mean, in my mind, technically be focused is on not the patients that already have insurance. They should be focusing a lot on the patients that don't have insurance at all.
Yeah.
Thank you. And I think we have perhaps time for one more question. And Eva, I saw your hand up. Want to make sure we get to that if it wasn't already addressed.
No, please go ahead and continue on with the questions. I think between the Isabel and Dr. Miggs back and forth, my question was answered. So thank you.
Okay, great. I think the only question I see in the chat that hasn't been answered or we haven't shared is from Gary. You touched on administrative bureaucratic concerns approaching institutions. Do you find that lesser funded institutions shy away from these types of studies?
And so, and I guess my question would be, what types of studies specifically?
Genomic, you know, precision medicine and things of that nature.
You mean just the testing, not an actual research study, but the testing?
Yeah. That's a really good question. I think there's a tension there because, again, thinking about, I work with a lot of folks across the country in, you know, Wisconsin, right? I'm working on the East Coast in Wisconsin, Colorado, and California right now. And they vary in terms of the kinds of you know, clinic and academic setting, academic medical center that they're and the populations they're serving. And I would say that no, I would say that it's really more the people that are working there. It's really more about them. It's about, you know, are they motivated and how much do they want to help their population? So I haven't, you know, anecdotally, again, I'm just going anecdotally off of my experience. I would say it's less about how well funded the institution is, and it's more about how motivated the providers, the staff are in helping to engage these industries, a lot of times industry or manufacturer sponsors, engage them and go through the bureaucratic process and the administrative process rather than, you know, how well funded it is.
From a global perspective, do you find these same barriers existing across the board, right? So if you go to Europe and or, do you
Such a good
find?
question. Yeah, so I actually, so one of I mentioned the Hexi method that I use. I engage, in fact, I just got back from Norway at a conference there. I engage with my peers across the globe. I've asked the same question. We have unique, I mean, you're probably not surprised to hear this. We have unique barriers here in the United States because we're a multi-payer system. And if you think about genetic testing, right, in most cases, that knowledge is going to benefit the person, later in life, let's say, and so there's not really in a multi-payer system, health insurance. We change health insurances a lot over, like if we have employer sponsored care, until you get to Medicare, you're going in and out of different types of plans often. At least I know I have over my course of my life. And so there's not that, the insurers are not motivated to pay for testing, obviously, but all the other things, because they know that it's going to benefit someone, it's likely to benefit another payer, And so those kinds of issues don't exist in a single payer system like what they have in Europe. And so those are really, you see similar challenges to getting access to the testing, but in some cases in other countries and other populations. But really what we have here in the US with our multi-payer system, and that's the way, if you really were to ask me, like, what would you really wish for, Emily, if you could wave a magic wand, it would be a single payer healthcare system for that reason. So I hope that answers that question.
That's great. Thank you so much. And I don't see any additional questions in the chat, but wanted to touch base with Lisa, given that Lisa's a part of the precision medicine work group, and ensure that we've covered questions for you. We can also have a follow-up discussion with Emily for the work group if that's
Yeah, I was
desired.
getting ready to put in the evaluation. I'd love to have a follow-up because there was a bunch of questions that came up at our joint advisory committee meeting that would warrant a further discussion, but obviously we're running out of time.
Wonderful. Yes, please. Eva has put the evaluation, a really short evaluation, in the chat. So please complete it. We love to hear from you and get your feedback on providing resources to this space. Thank you all for joining us. I hope you have a great rest of your week. Thank you, Dr. Mrig, for joining us, and really appreciate your insights into your work, and excited to hear more about how your work evolves.
Thank you.
Thank you all.
Thank you. That was a great talk.
Thanks. It was great to be here.
Peace and blessings.